We're doing a transabdominis plane block here, or a tap block. You can tell we're going to go midway between the iliac crest and the lower costal margin. Usually ends up about the level of the umbilicus. We'll put the probe just on the anterior abdomen. To the right of the x-ray screen, you can see the rectus abdominis muscle and the internal oblique coming up and embedding the rectus abdominis. You can see the rectus abdominis a little more in the picture there. And then as we start sliding laterally, the internal oblique meeting the rectus abdominis, the external oblique more superficial than the internal oblique, and then deep to the internal oblique is the transverse abdominis muscle. And the plane we want to get to is that plane between the internal oblique and the rectus abdominis. So we want to get in this plane here. So external oblique, internal oblique, transversus abdominis muscles. This is a classic look. You're going to see this on all patients. It's just very, very consistent. The difference is going to be between the external oblique and the skin based on the adipose tissue in each patient. So we're putting our local in. I'm going to start. I have the probe in kind of the anterior axillary line, and then we're going to work from medial to lateral. This is the one block you can actually go medial to lateral, or you can bring your needle in from the lateral side of the probe and come back medially. The key is ending up with most of your volume back to the lateral aspect of the muscle, or the lateral posterior end of the muscle. You can see our local infiltration coming in from the right side of the screen. And then we're going to get our sonoplex tui and bring it in with an in-plane approach. It'll be coming from the right side of the screen, going left, and then we'll take it down and try to open up the plane between the fascial layer of the internal oblique and the transversus abdominis muscle. You can see the needle coming in. The last 2 centimeters have the echogenic properties of the Payank needle that make it very easy to see when you're coming in at an angle like this. So we're approaching the transversus, or the tap plane here, trying to pop in that plane. Looks like we're there. No, we tried to inject just a couple cc's there. You can tell it was still in the internal oblique muscles, so we're going to advance a little bit further, try to feel this pop to get in between these two fascial layers. When we start injecting, it should open right up, kind of like a river opening up. So trying to get the needle adjusted just right. So you can see this needle very easily for the most part. Here we are. You can see the needle well. There we are. It looks like it's in a great location. So we start injecting there. Very easy to see the plane of the transverse abdominis muscle and the fascial layer of the internal oblique open up. And so we're certainly in this plane between the two fascial layers of the muscles. We're injecting, and we advance the needle more posteriorly under the probe. So you can see we keep opening up our space and advancing our needle, trying to get to the posterior edge of the transversus abdominis muscle. And that's where more nerves are transversing through this plane, and that's where you're going to get more extensive block and more multiple levels. You can block up to as much as from the T7 to L2 with high volume placed posteriorly. You can see we've opened up this plane extremely well. It's a beautiful picture. Really great view of the needle. And as we're coming through, opening up this plane, and we're trying to get more posteriorly. Of course, with the abdomen, it's constantly moving. So the needle sort of comes and goes a lot. You have to stay on it. Now we can see it again well. You have to keep adjusting your probe to maintain that needle view. The tap plane has been opened up with local anesthetic. Now we're back we're going to try to inject some more, open up that plane, and keep advancing our needle more posteriorly. The beauty of this needle is when you come in at an angle, at a steep angle, and you do have to come most of the time. You can't come at a flat approach like you do some blocks where you see the needle well. And this echogenic needle really helps be able to see exactly where your needle is when you're coming in at an angle because it has that advantage of those last 2 centimeters that you saw right there. This allows you to see the tip because you have to see the tip, and if you can see it well, it helps you be able to feel that pop and actually see the pop when you get in the tap plane with the tip of your needle. Here we are pulling our needle back out. We've finished. We've opened up our plane. Going to have a successful block. The whole tap plane is opened up with local anesthetic, as you can see there. This is a high volume procedure. It works best with high volumes. We use 30 to 40 cc's of volume. If you get that volume posteriorly in the tap plane, it allows the spread of the local to get the dermatomes of nerves T7 to L2, and so you get more spread of local and more of a broader aspect of block as more nerves are coming through the tap plane.